Hello, I'm Sujit Rajan, consultant pulmonologist at the Bombay and Bhatia hospitals in Mumbai, and I welcome you all to Season 2 and Episode 10 of Healthcare Superstars. In the first season, we have seen some amazing cases within the ILD spectrum, COPD, and asthma. In Episode 10, and significantly based on audience demand, we again move to an important area of concern, which is asthma and COVID, and more so with the waves of COVID that we've been seeing across the world. In today's episode particularly, we shall be addressing the much debated issue of diagnosing and managing asthma in a COVID era, both acutely and with long-term symptoms. And before I move forward with inviting our speakers, I would first like to thank our collaborators, which are the Sri Lankan College of Pulmonology, the Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPATH from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. I'd like to first introduce Dr. Alan Kaplan. He's been with us before on Healthcare Superstars. He's a board member of the International Primary Care Respiratory Group, the IPCRG, and he's a member of the Health Quality Ontario Asthma Standards Group as well. Alan has been the past chair, CPFM Respiratory Medicine, CFPC, and has over 480 presentations at different international and national conferences. He's acted as a principal investigator in 50 clinical trials, and he's also the international editor for Nature's Primary Care Respiratory Journal. He has over 145 peer-reviewed publications and 104 abstracts. So Alan is no stranger to respiratory medicine in primary care. Welcome, Alan. Our other speaker is a renowned respiratory physician, Dr. Louis-Philippe Boulay. Louis-Philippe is a member of the ATS-ERS Severe Asthma Committee and chair of the Board of Directors Global Initiative for Asthma, GINA, which so many of you all know about. He's also the president of InterAsthma, the Global Asthma Association, and a past chair of the Canadian Thoracic Society. He's the Laval University Chair of Knowledge Transfer, Prevention and Education in Respiratory and Cardiovascular Health. Louis-Philippe has written more than 650 medical publications, 633 abstracts, 43 book chapters, and authored 17 books. His area of significant research is exercise-induced asthma, and we welcome Louis-Philippe for today's web meeting. Okay, so over to you, Alan, for your first case.
Thank you very much. Thank you so much for having me. I've been tasked to talk about COVID and asthma, the lessons and the learnings from this pandemic. You all recognize the coronavirus there, and you understand the name of it came because it's shaped like the crown of a king. So that's where this name came from. So I thought I'd go through a case together with us as we go through COVID and the alphabet of different viral variants that we've had through times. So in 2020, this 45-year-old moderate asthmatic who was well controlled on a moderate dose ICS LABA as well as a LAMA and a SABA PRN with a reasonably normal lung function FEV1 88%, although interestingly giving him more medications actually did not improve that lung function. He's been exacerbation free for 3 years. He uses a SABA a couple times a week, if that, usually for exercise. So we would define him as being controlled. He never wakes up at night because of his asthma. But he was very worried about this COVID alpha wave, and he heard all kinds of noise about how steroids might worsen the COVID effect, and it could worsen his risk of getting COVID, and the immune problems seems to be the issue with immune issues causing the problem with COVID, and don't the steroids worsen immunity? And in fact, he was so worried about this that he, like many of our patients, actually stopped their inhaled steroids because of the concern about this. The first, of course, is we all know that the relationship between asthma outcomes and treatment is very clear. The more ICS you use, which is on the right, the less exacerbations you have. And conversely, the more SABA you use on the left, the worse the outcomes are. So clearly for a patient like this, stopping their inhaled steroids and continuing just SABA could be disastrous. Then there was a bunch of data, and although this is a more recent publication, it dealt with the first viral outbreak, and they looked at outcomes of asthma in people in Scotland. And what they found here very clearly is looking at the people with just asthma alone, without severe asthma, no oral steroids, actually did not have a higher incidence of COVID and had no increased incidence of more severe COVID. But there was an issue of people who were on oral corticosteroids. So if they're immunocompromised with the oral corticosteroids, they're at risk. But even stopping oral steroids is recommended against, because that could put them at risk for worsening asthma as well as adrenal suppression. So again, we recommended not stopping even the oral steroids, but reducing it if possible. So that was really the concern, those people who were really immunocompromised on oral steroids, but not the everyday asthmatic, even a moderate one like this. And then soon afterwards, there was work done with the STOIC in the principal trial that looked at the use of budesonide, 800 micrograms twice a day, to attenuate the effect of COVID. And what it actually showed, if you compare it to usual care, there was a much faster recovery, higher likelihood of recovery in those groups that actually had budesonide treatment versus those that didn't. So in fact, it was clear that the use of inhaled steroids may actually be a benefit even to the non-asthmatics to prevent worse outcomes for the COVID.
And Alan, there was this concern about inhaled steroids and how they work, and I see you've put up a slide on the ACE receptors. What exactly happens? Is it the ACE receptor that gets upregulated or downregulated? How does the inhaled steroid really protect against COVID, or is that still not known?
Well, there's a lot of theories to that, but I think the one that makes the most sense here is that the spike protein has to attach to the receptors in the lung. And it seems that to the ACE2 receptors in the lung, and it seems that inhaled steroids actually downregulates those ACE2 receptors in the lung, therefore making less points of attachment and hopefully therefore less bad outcomes in terms of the COVID. And this was actually shown also when it came to nasal steroids. This article in JAMA sort of looked at people who were or were not on nasal steroids. And you can see here in the top left corner, the group of people that were actually on nasal steroids had better outcomes than people that were not on nasal steroids for other conditions. So it appears that the spike protein can attach anywhere in the airways, whether it's the nasal epithelium, into the upper epithelium, or into the lung itself. And by having the inhaled steroids decreasing that ACE transmission and attachment, we decreased COVID outcomes. So this gentleman went back on his medications. He continued to be controlled. He did all the non-pharmacologic treatments. He used social distancing, used a mask, although he didn't like it, and he remained COVID-free. And of course, this was prior to vaccinations, of course. So he stayed lucky in the alpha wave. He did not get a COVID infection or a bad COVID situation. But of course, as we moved through the alphabet of variants, then came the Delta variant. As you recall, this seemed to be a little bit more virulent. It was first reported, at least in Canada, April 2021. And it became quickly the dominant variant both here as well as around the world. And of course, you in India know this very, very well. And then the vaccinations sort of came. And in Canada, we first had the AstraZeneca vaccine, then the Pfizer vaccine, and a little later, the Moderna vaccine. So then we had people who, of course, wanted these vaccines as soon as possible. But because of supply issues, we had to have very significant risk stratification for who should be getting the vaccine. And the vaccines were being given, of course, to people who were older, people with immune issues primarily first. And of course, according to this man, he says, well, I have asthma, so why am I not high risk? And he was actually very upset that he actually could not get a vaccine. So I explained to him, of course, that that's not the way this goes in a time of not enough supply. So is the elderly, the immunocompromised, people living with housing issues like the indigenous or in older age homes. And then a little bit later, that followed with chronic illnesses like heart failure, COPD, and diabetes. But asthma, because of the data, it actually did not show that asthma was a high-risk group for contracting COVID, or in fact, for more severe COVID either. So with that explanation, he went away not very happy, but subsequently he did get vaccinated as soon as he could. The first vaccine we had available in Canada in good amounts was the AstraZeneca vaccine. He was eligible for that, and he got his first one, and then he came back to get his next one at 12 weeks, which was the timing that was recommended in Canada. However, he was a little frustrated, but he kept taking his medications. He stayed controlled. He did get vaccinated as soon as possible. Well, then time marches on, and we move on to the Omicron variant, and this made it to Canada in the end of 2021. And I think we all recognize this is a different animal. It had more than 30 variations in the spike protein, which made it actually more transmissible. The big question was it less virulent? And it probably is a combination of being somewhat less virulent as well as a significant part of the population getting vaccinated. But even in South Africa, where this first was actually shown, the death rate was much less with the Omicron than the previous variants, although of course a lot of people at this point had COVID as well. Well, with all this, a lot of people were getting what we called COVID fatigue. They were tired of the social distancing, they were tired of the masking, they were tired of staying away from family and friends. They missed things like sporting events and restaurants. And he's wearing his mask, and he did keep to it a lot, but of course, people just got tired and stopped being quite as careful, and some of the restrictions were left. So why was that? Partly because of data like this. And if you look at the Delta variant on the left, you could see there's lots of hospitalized cases, lots of people in the ICU and the ventilator. If you compare that to on the right with the Omicron situation, lots of infections. Some people still got hospitalized, but many less that ended up in the ICU and on a ventilator. And it appears also about Omicron that actually it tends to infect the upper airway more than the lower airway, which may be another one of the reasons why it's not quite as severe of a variant.
Were there any differences between these two waves in the asthma management, particularly, Alan, and then Louis-Philippe?
Well, any virus could precipitate asthma exacerbations, as you well know. Right. But I don't think that was really the big picture here. The big picture here, of course, with COVID that was different than other things that previous SARS viruses, of course, was that you're infectious before you actually got sick. And the other big issue with Omicron is you're infectious and not necessarily sick. So that became a big issue in terms of being careful. And for me personally, I had started opening up to do spirometry and so on in my office again. And I had to shut that down again because, of course, everybody could have Omicron, and sort of testing everybody all the time be very difficult. So we put the spirometry testing on hold in our office, and we're just going to start opening that up again right now as the numbers are falling. Louis-Philippe, what happened with you?
That's great. The spirometry opens up another Pandora's box. But Louis-Philippe, please.
Well, yeah, that's very interesting. In fact, I guess we initially we were very concerned about asthma exacerbation, but as we said, in fact, they had less asthma exacerbation, and in fact, the flu season was almost negative. There was nothing, so we were confident. But with the relaxation of the measures with the Omicron, people were not as good at the public health measure as before. Surprisingly, it's not the COVID that gave the problem, at least in my practice. It was mostly the other viruses. In fact, when people were not wearing masks or paying attention to contacts, they were getting other types of viruses that make them exacerbate. So surprisingly enough, it was not really the Omicron that was the big problem. It was the other types of viruses. But of course, we were concerned about the immunosuppressed, those who were on oral corticosteroids, although there are not many of those. But then we insisted on the measure in these patients, and it went well.
And that's fantastic. Excellent perspective from both of y'all on this issue. Just one question to you, Louis-Philippe, on spirometry. So what's the current guidance, Louis-Philippe, in your department?
Current guidance is that when the patient come for a spirometry, they test themselves. It's not the PCR, but the other test that is simpler that they can do at home. And if they are positive, of course, they don't have the test. If they are negative and they don't have any symptom, they can come to the lab to have the test. But of course, the precautions are taken by the personnel with the mask and the blouse and everything, to be sure that with some air movement also in the room, to be sure that we don't disseminate the virus in case they have some.
Please carry on, Alan. Please.
However, with all this, this gentleman then ended up getting sick. He had a bit of a cough, and he said, "Well, listen." He at this point he was triple vaxxed, so he says, "Well, I can't have COVID, can I?" But he did have a fever, and he was a little bit more, getting to be a little short of breath. But this cough was the bothersome thing, first of all. So he didn't have any loss of smell or taste, which, as you know, was a common issue with the Alpha and the Delta, but much less common with the Omicron. So he got a COVID PCR, it was positive. So yes, he's infected with likely Omicron at this point. And of course, he was very scared. Remember from the beginning, this guy was very worried about this from the beginning. So now he says, well, am I going to die? And I don't want to die. So what can I do to end up not being in the hospital? Because I think there's some treatments now for COVID, isn't there? Which of course there wasn't initially. So the question then was, is he high risk enough to get some of the very expensive new treatments? Or what are the combinations there? So There are some monoclonal antibody therapies that are available. We have one currently in Canada, sotrovimab. There's many others available in the United States and other places. But the list of people who's eligible for this is kind of restricted in order to be able to keep supply. Recently, we have the combination antiviral oral pill called Paxlovid. It just got approved. We don't have supply of that just yet, at least on a routine basis. So he wasn't considered high risk enough, and there's a set of criteria for both of these. So in primary care, when these people are not sick and they're not high risk, what are our other choices? So in this particular case, however, because he was already on triple therapy for his asthma, there really was no evidence for adding on budesonide on top of that. So with no evidence, we decided to go the trial of fluvoxamine. Here's the dosing, as I mentioned, 50 milligrams a day for a day, then 100 milligrams twice a day for 2 days, then 100 milligrams 3 times a day for 15 days.
Have you, Alan, seen an uptake in the inhaled steroid usage during the pandemic? Because we've seen a huge uptake in acceptance of inhalers and inhaled steroid use. Have you seen that in Canada as well?
We've seen it in Canada, and actually it's been published in many places around the world that people were much more adherent to their medications for both asthma and COPD than really ever before, because they were afraid. And therefore they said, I'm going to take my medication because doc said I need to keep my illness there because that's the best thing I can do for my COVID.
Another reason to improve adherence, COVID. Just imagine, we would never have thought of that earlier. Please continue.
It actually helped some other things as well. Smokers, for instance, were also known, at least in the alpha and delta waves, to have a much higher risk of having more severe COVID. And it became something to actually get people to quit smoking as well. Wow. So, even though this has been a disaster around the world, there's actually been some silver lining. Yeah. And so I just wanted to show that, this sigma-1 receptor agonist endoplasmic reticulum chaperone protein, which is different in fluvoxamine than others, is really why you can't just replace one antidepressant with another. So he did this and he recovered, and then he was concerned, well, okay, am I going to get long COVID? And of course, now there's a lot of noise about long COVID and people not recovering for that. So he said, well, what do I do to prevent long COVID? Should I get yet another vaccination? Is there anything else I can do? So I just thought I'd share with you an article, first authored by a friend of mine, Rupert Jones from the UK, that looked at those people that we could sort of predict the likelihood of getting long COVID based on their situations. And you can see, obviously age and a little bit more for the female sex, and for higher BMI, and smokers were higher, and frailty, which was a higher risk. But in terms of respiratory illness, we look at asthma and COPD. The increase in asthma was very small there. You can see it does cross 1, so that wasn't very impressive. COPD, on the other hand, was a little bit more impressive.
And so superb case, Alan. A lot of learning points there. Thank you so much. I'll move across to Louis-Philippe for a short didactic talk on how GINA guidance has changed in the last 2-3 years. I mean, we have seen updates almost every year. And so I think for primary care physicians to just keep up with that, what are the key messages in the last 2 years? Louis-Philippe, you have been involved closely with GINA. Over to you.
I wanted to initially just show 2-3 slides about what GINA recommends in regard to COVID. And it will reiterate, in fact, what Alan said. I think people with asthma, particularly when they are controlled, do not seem to be at risk of acquiring COVID or having a more severe COVID. It's those with an unstable, uncontrolled asthma or on OCS or oral corticosteroid that are maybe at risk in this case. So I think it's reassuring for everybody. And the implication in regard to asthma management, we said that the major point is to get control, not to lose the control, keeping the good medication that is required and using the ICS, the inhaled corticosteroid when needed. So we see that many studies have shown now that there was a reduction in asthma exacerbation throughout the pandemic, probably because of the measure that were taken, the health measures. In regard to the medication, we said we have to pursue the medication to adapt according to the level of control. All asthmatics should have an action plan on which is written what to do if they worsen. And of course, we have to avoid everything that will increase the risk of spreading the virus, such as nebulizers. And of course, we spoke about spirometry to be careful about that. Of course, once again, GINA suggests that the booster shots should be offered. We suggest, in fact, that if they are on a biologic, for the more severe types of asthma who are on a biologic, that the vaccine should not be given on the same day. It should be, this will allow us to see if there are side effects to this drug or to the vaccine. And of course, influenza should still be given. It will be important to prevent that, even if the rate of influenza is quite lower than it was, probably due to the health measures.
Over to you, Louis-Philippe, for the second case.
Thank you very much. So I'll talk briefly about long COVID, because this is one of the concerns that we all have these days. Let me talk about John. John, in fact, is a 30-year-old man that had moderate atopic asthma since childhood. He had an allergic rhinitis. He has GERD, also gastroesophageal reflux disease, that is treating with the PPI sometimes, but sometimes some other agents. His optimal FEV1 was 82% predicted, so not too bad. His FEV1 over AVC usually was around 70, 72. He had a diagnosis proven from bronchodilator response. In this case, he did not need a methacholine or another type of bronchoprovocation test. He was on a moderate dose of ICS to be controlled with formoterol, BID plus PRN, so he was at the marked type of treatment. He was relatively adherent to his treatment, I must say. I always ask the percentage of adherence, and in his case, he said, "Oh, you know, Doc, I'm probably 70% adherent." I said, "Okay, that's probably a bit lower, but okay, I know that." He was well controlled until he was diagnosed with COVID-19. Well, his asthma, in fact, exacerbated. It was a Delta. His asthma exacerbated slightly, but he did not need, in fact, hospital admission. He has increased, in fact, slightly his ICS with some benefit initially, but for the following months, in fact, he had a persistent, troublesome cough, and he was still complaining of dyspnea on mild efforts. He had to stop training. He was unable to keep his usual training at the gym. And he tried to increase his asthma medication, but once again, it had some limited benefit, and he was wondering what was happening there. So the respiratory symptoms were affecting his daily activities and sleep. So this is, I guess, a relatively typical case that we see sometime following COVID. Even if they're not more at risk, of course, some asthmatic can get it. And we have to ask the question, is it really a long COVID that is getting installed? Is it asthma that is difficult to control? Is it deconditioning because he stopped doing anything because he was too dyspneic? What about the cough? Is it due to a worsening of his GERD, all the medication that he was taking in fact before, or trying to get rid of his symptom? Were this increasing the GERD problem? Was it due to the COVID or the post-COVID problem, or another cause? So of course we have to look at the differential diagnosis. So of course we said that, first, long COVID is, how long is long? So there are many suggestions. For example, in the Young COVID review in 2021, it's interesting because it showed, in fact, all the criteria that the author chose to decide that it was a long COVID. So it's very variable from an author to another, as you can see. I like, in fact, to look at the UK NICE guideline about that. They said long COVID is referred as a post-COVID condition, post-COVID syndrome, or post-acute sequelae of SARS-CoV-2 infection. So they say it's symptoms that develop during an acute COVID and continue for at least 2 months or 3 months from the onset. They are not explained by an alternative diagnosis. This is why we have to do a differential diagnosis from the start. And what's interesting is that they have 2 types of so-called long COVID. In fact, there is an ongoing symptomatic COVID. It's simply that people have a COVID and the symptoms are still there between 4 and 12 weeks, and they did not resolve. And it's like the acute event is prolonging slightly up to 2 to 4 to 12 weeks. And for the NICE guideline, they suggest, in fact, that we can really think or speak about long COVID or post-COVID-19 syndrome if they have more than 12 weeks, symptoms more than 12 weeks after the start of the acute symptoms. But as you can see, once again, there are many opinions about that. And of course, when we see a patient with symptoms like the one I showed, Alan was very right, in fact, telling about different conditions, because it can be a lung problem, it can be the asthma problem, it can be a heart condition, because there are many problem, myocarditis and all sorts of problems following the COVID. They have neurologic problems, sometimes all sorts of other types of problem, even gastrointestinal, and of course blood vessels problem associated with coagulopathy sometimes. And if you look at the mechanisms to explain these side effects, particularly at the level of the lung, what you could see is that there may be, following COVID, a persistent chronic inflammation with production of cytokines and reactive oxygen species that are released continuously into the tissue in the bloodstream. And this may persist for quite a few weeks or months sometimes. They may also have some endothelial damage. It can lead to fibrotic changes in stimulating the activation of fibroblasts and the deposition of collagen. So it's a kind of scar tissue that can lead to a kind of fibrosis of the lung. And of course, there is this endothelial damage that leads to an activation of the coagulation pathways and lead to a prolonged hyperinflammatory and hypercoagulable state, so with potential thromboembolism. So there are all mechanisms that can occur after, in the months after a COVID problem. It was more about the Delta. I don't have many data about the Omicron, if it's as bad as that for this type of problem, but we'll look at it. But the differential diagnosis for dyspnea or an even cough sometimes is not only related to the lung, and we have to look at the different systems that can produce, in fact, these symptoms, as mentioned on this slide here. And psychological are part of it for anxiety, as I mentioned. So Alan showed this slide, and he showed that there was a very mild increase here in potential risk prediction of COVID, long COVID, for asthma and COPD. For asthma, this is for COPD, but the upper one here is for asthma, just at the top here. For asthma, it's almost non-significant. It's mostly for COPD here. And for asthma, if there is a risk prediction, it's mostly for very severe uncontrolled patient on OCS, where we can predict that it may go not as well as we expected. So the symptoms, we spoke about that. It can be fatigue, dyspnea, chest pain, cough. There are so many of those. As I said, there are 200 types of symptoms that have been described for long COVID. But it's mostly, in fact, dyspnea and cough. The other ones, of course, can occur if there is another system affected. And of course, the prolonged symptoms are common even in patients with less severe disease who were never hospitalized. So even if they had a mild COVID, this can lead to prolonged symptoms that can be part of this syndrome or condition. So there are many patterns that have been recognized, of course. For most of the people that have been infected and did not require hospitalization, we almost have no studies on these patients. We don't know exactly what's happening in those. So we need more studies to look at this condition.
Louis-Philippe, just your feel of Omicron. It's just been about 2 months into Omicron, probably in Canada where you practice. Do you think you're seeing long COVID symptoms? Because we are seeing at least 4 weeks plus. We haven't yet reached the 12-week mark, of course. What is your sense?
Oh, absolutely. Yeah, we have Omicron that lead, in fact, to persistent symptoms for quite a few weeks. My prediction is that there should be probably some long COVID with Omicron. As for the Delta, I don't know the proportion, however. Sure. We know that with the Delta, it can go up to 30% of those who had a COVID with the Delta. I was trying to get some data from South Africa, where they had Omicron before us. Yeah. It's not sure right now, but I don't see why we should not have a long COVID with Omicron. It should happen, but hopefully it will be less than Delta, but I'm not sure about that.
Great, thank you.
For asthma, in fact, there are studies that have been published on non-COVID in asthma. This is one interesting one by Philip. And if you look at the persistent of breathing problems, this is in fact those who have no long COVID and those who have long COVID. And this is the breathing change from before having COVID-19. And in fact, it's interesting to see that, of course, the much worse than before is a little bit, is longer, is worse than for the non-long COVID. There is a certain degree of severity for if you had a more severe COVID initially. Probably if you had more symptoms, then it's persisting a little bit more. But once again, it's difficult to conclude absolutely between that. The cough is also a symptom that is very common. I was very interested to look at this study by Song that reported acute and persistent cough following COVID, mostly Delta here again. Of course, it's quite variable from a study to another, but interestingly enough, in some groups, in fact, the persistent cough is quite prevalent in regard to the acute one. So it's a symptom that can persist for a long time. And there have been studies on mechanism by which COVID can lead to, in fact, a persistence of cough. And the basic principle is that it's probably affecting the neurologic pathways. It may be influencing cough from an effect on the brain with cytokines or mediators that are affecting the cough centers in the brain, or it can be probably affecting the peripheral nerve, the afferent sensitive nerves. But once again, I think dry cough is one of the most common symptoms of COVID with dyspnea. And of course, the management of this with COVID is really unclear right now. It's difficult to treat that cough sometimes. They are suggesting, in fact, the same approach as for the other refractory cough, even gabapentin sometimes. But once again, we don't know exactly how to treat these cough. As mentioned here, they think it's an invasion of the vagal sensory neurons that bring, in fact, the message of the urge to cough to the brain. So this is really something typical of a long COVID syndrome right now.
We've sometimes used gabapentin, Louis-Philippe. Any precautions that the GP should take when using it? Any advice to the patient?
I think when we are up to gabapentin, it would be better for the patient to be looked by a specialist, because we really have to be sure that it is the case. There are so many other conditions that can be related, can be causing, in fact, a chronic cough. I mean, if you look at the cough guideline, the American College of Chest Physicians, the differential diagnosis of persistent cough, you really have to go through the differential diagnosis. And if it's a refractory, unexplained cough, if you try to find a cause and you don't find a cause, then probably you can go to these medications that are not without side effects. Of course, they have a lot of side effects. So we have to be careful about that.
Yeah, Alan, you'd like to comment on that? Because, it's rare that we've had to go to gabapentin, I must confess, Louis-Philippe, but being a specialist, when you get patients who you've tried anti-reflux, the antibiotics, inhaled steroids, sometimes even a short course of oral prednisolone, we've had to go to gabapentin, and very rarely even low-dose short-acting morphine. Alan, your thought?
Well, the way I like to describe it, and for the primary care physicians, it's just like you're treating neuropathic pain.
Right.
And when you treat neuropathic pain, the nervous system actually changes in a process called neuroplasticity. In this situation, the neuroplasticity is affecting both peripheral and central nerves, with central hypersensitivity as well. So the way you would use gabapentin or pregabalin or something is just like you'd approach it with chronic pain, which is start low and go very slow. But again, I think the emphasis on what Louis-Philippe says is make sure you haven't missed something else before you just chase the symptom.
Absolutely. Thank you.
And I think a chronic cough or persistent cough should be treated as any other persistent cough. We have to do the workup. And if I can make a recommendation of an excellent reading, of which Alan is an author also, is there was a guideline published, a state-of-the-art paper in the Canadian Journal of Respiratory and Critical Care Medicine recently by Imran Satia, S-A-T-I-A, as the first author. You'll find everything you need to look at persistent cough in this wonderful paper.
Fantastic. Good message. And we hope everyone who's tuned in will read that. Thank you.
Yeah, you should read that.
Thank you, Louis.
So anyway, this is just in fact a couple of slides to finish on some recommendations that have been proposed for clinical investigation of these post-COVID symptoms that are persisting. This once again is from the NICE, the UK NICE guideline. Of course, full blood count. You never know what you can find. They're doing kidney and liver function tests, C-reactive protein tests. They suggest in fact an exercise tolerant test. During this test, you're measuring, of course, heart rate, breathlessness, and O2 saturation, which is very key, and a chest X-ray, in fact, for all patients that by 12 weeks after the first infection. So I thought it was an interesting first step. The only thing that is missing for me, if you have a patient that had already a respiratory condition, is that I think I would add a pulmonary function test to that. But that's interesting. I think in airways disease, I think we should do this lung function test, and of course always consider alternative diagnosis. And don't forget, and Alan said that, thromboembolic disease. It's so often that sometimes, where pulmonary embolisms are missed. It's always my nightmare. If there is anything that is wrong or I don't understand, I have to check for that too.
Sure.
So finishing with that, post-COVID evaluation, this is not an easy task. It's always interesting to have a multidisciplinary group, in fact, to look at these patients. And there are many studies done in Canada right now on how to manage these patients the best. And of course, we have to have to speak to the patient to really dig into what he thinks about his condition, to have a goal that is achievable. Most post-COVID conditions can be diagnosed and managed in primary care, but I think we should have the availability of a multidisciplinary care center if it's a bit too complicated or if it does not improve. And of course, we have to avoid excessive testing, as we always say. We tend to do too many tests. I don't think it's everybody that should have a CT scan or another very invasive test, like a bronchoscopy or something else. We have to have clues, in fact, to indicate that there is a need for that. And of course, we should be step by step looking at the different diagnoses. I won't go through that. Sorry. This, in fact, the last two slides were simply a summary of the NICE guideline. You can have a look at this. This is in fact a table that reiterates in fact what I just told you in regard to the step-by-step management of these patients, up to the management, the follow-up, monitoring, and of course looking at all the aspects of care and all the aspects of potential diagnosis, as I mentioned, including in fact physical, psychological, and psychiatric aspects of rehabilitation of these patients sometimes who are in trouble. So I think I will conclude here saying that I think it's common, the long COVID. It should be distinguished from other conditions that can be treated separately, or like uncontrolled asthma. A systematic evaluation, a step-by-step evaluation should be performed. We should do enough tests, but try to avoid over-testing. So this is not an easy task sometimes. Thank you for your attention.
Fantastic presentation, Louis-Philippe. I think there are so many important messages to clinicians here that don't forget your basics in respiratory medicine when it comes to long COVID. Evaluate the patients just like they would, but a very interesting space in respiratory medicine, which I'm sure we're going to read more about. I liked the fact that you all had a duplicate of those slides actually on the risk factors for long COVID, because they're so important. Subtle features there, I thought. The female aged above 40, which is what we see in clinical practice, and we don't know the reasons why. And maybe it could stem from what Alan said. Maybe a little more anxiety, but I don't want to be gender biased here. But we could have so many issues here that contribute, that we'll probably learn more about in the coming months. Thank you so much, Louis, and I will ask Alan to wrap up our webinar with a 5-minute presentation on some key messages for primary care physicians in 2022 after what we've learned in the last few years.
So what are those 5 key lessons for primary care practitioners to understand in 2022 with respect to asthma? The first, of course, is take your medication, be in good control. That's the key thing here. And if you're not in control, what's the quick approach to this? An article wrote in 2008. Well, do you have the right diagnosis? We touched on that already with the long COVID. Is it asthma or something else? Are they adherent to their medication we talked about? Are they using their inhaler properly? If we don't deliver the medication to the proper lung, it doesn't work. Comorbidities have to be dealt with, we touched on. Triggers have to be dealt with. And of course, some people need to have more severe disease and have to be stepped up. This is a quick little cartoon talking about inhaler technique, which is not intuitive. Yes, it's kind of complicated. You stick it in your mouth and squeeze your head. Well, it's not as bad as suppository. That's not a respiratory product, but just a little levity. The second key lesson, of course, that SABA monotherapy is still bad. And Louis-Philippe alluded to this in the GINA recommendations. Here's some evidence for that he didn't show, which is from the Sabina trial. This was in Sweden. And they found that people that used 3 or more canisters in a year, even if they used other products and other controllers, had an increased risk of, in this slide, exacerbations you can see there. And in this slide, you can see the risk of death, both asthma death and other mortality as well. So it appears that SABA use is a marker of risk. And therefore, we want to make sure that people use the least SABA possible. And Louis-Philippe has already talked nicely about anti-inflammatory therapy. Another article by Chen, and this goes back to 2018, is people that tend to rely just on their SABAs develop more severe disease over time because they're not treating the inflammation, and mild disease becomes more moderate becomes more severe, and so on as time goes on. So treat the inflammation is the message. And that's, of course, Louis-Philippe talked about this in great detail already, but ICS at every step in the GINA recommendations, whether it's track 1 or track 2. And I'll remind you, even in track 2 here, where there's no ICS for Moderol, there, an ICS should be used even for mild disease every time you take a SABA. The third lesson is going to be get vaccinated. And we're going to talk mostly about COVID here. And here is some information from Los Angeles, California, that talked about people who were not vaccinated had 23 times the risk of being hospitalized because of Delta variant. And the same situation has been showed with Omicron as well. And you can see here, if you look at the dark blue, these are people who are unvaccinated versus the wholly vaccinated, which is the hatched small lines. The really big difference between those people that end up in the hospital and so on. So being vaccinated is important, and getting at least 2 doses and probably 3 is going to be important, as we mentioned earlier. The fourth important message is something that we were seeing more and more of, which is not just the people on steroids every day, but people with recurrent exacerbations and requiring oral steroids a few times a year. So oral steroids is bad. And in primary care, we recognize all the harms of oral steroids. And oral steroids, here's some short-term and long-term effects, whether it's mood issues, sleep issues, hypertension, sodium abnormalities, increased risk of fracture, DVT, and sepsis that's been shown, glaucoma and cataracts, weight gain, osteoporosis, risk of diabetes. All these things are there. So the use of steroids really are something we should be very cautious about, and we should not just take this as a for sure thing that people are going to need steroids a few times a year for their exacerbations. This is some work done out of Taiwan that showed if you look at the 30 days after someone's had a course of oral steroids, they have a higher risk of GI bleeding, sepsis, and heart failure. And a very similar one in the United States showed the same thing for fracture. So again, even that short course of oral steroids has risks, so we need to try to avoid that. This is another trial looking at the risk of mortality in Korea. And those people that were on steroids fairly regularly had a much higher risk of mortality overall than people that did not need oral steroids. So the message here is that we should avoid the use of oral steroids. How do we find those people in your practice that should be considered for referred or an update? We call this the Refer ID tool. It's part of our Precision Canadian group, but this is an international program. He said, who are those people in your practice in primary care that you should identify as people who are risky? So people that have used already a couple of courses of oral steroids or been to the emergency room or hospitalized a couple of times, of course, they'll get steroids then. Anyone who's ever been admitted to an ICU at any point for their asthma, not for the COVID, of course, but for their asthma, the risk of mortality at 5 years is about 22%. It's a significant number. So we have to realize that these people are always going to be at higher risk. Even if they had milder asthma ending up in the ICU, as Louis talked about earlier, we should watch that. And of course, if they've used 3 or more SABAs per year, they're at higher risk of having exacerbation. So that's the message there. My fifth lesson is that shared decision-making does improve adherence. And in my mind, and I'm sure Louis-Philippe will agree, that the number one cause of someone not being controlled is lack of adherence. When they feel better, they stop taking their medications. So how do you get around that problem? Asthma is a chronic disease. We have to approach it that way. So I want to share you with an article by Wilson in 2010. And what they did in this trial is they just actually gave some extra conversation. So these 4 extra steps in a patient. So they identified the patient's goals and preferences. They summarized them back to the patient. They discussed the merits of treatment, and they came to an agreement, the patient and the clinician, about what the treatment strategy is going to be. So this is very much a non-pharmacologic intervention, trying to ensure that the patient was on board for the treatment strategy. And it's amazing the results. In the first year afterwards, they had more controller used, less SABA used, improved quality of life, improved asthma control, and having well-controlled asthma. So if we talk to our patients and involve them in the decisions that get made by us for the most part, but we have them buy into those decisions, the outcomes are always a lot better. Those are my 5 key messages. Thank you.
Thank you so much, Alan. Fantastic messages, and I'm sure so much to learn for primary care physicians that have tuned in. We have some questions coming in from other countries. The first I'll put across to Alan. How much of a primary care physician's time should now be devoted to online consults, in your view, Alan? As we come out of this pandemic, we see a surge of requests for online consults, some genuine and some just because they're lazy. So what is your view? What is your view?
Well, it's certainly a balance of the convenience for online or virtual or telephone calls with patients. And for certain things, those are wonderful for follow-up of chronic conditions, potentially for medication refills. But I think if you're seeing a new problem, we've already learned that you can miss an awful lot by doing a virtual assessment. You sometimes need to examine, you need to have those physical cues and clues. So I think that we need to be going back to in-person visits to do some of those things, because there's things we're just going to be missing. There's subtleties we're going to miss. So just be cautious of the fact that we're limited when we just use virtual care. So personally, what I do is I spend one day virtual care and 1 day in-person care. That's good it's good for my staff as well. We can staff accordingly with it. Obviously, phone calls are going to come up even in a day you're there in person, but we try to divide it up and try to make the office more efficient that way.
Fantastic. Okay, and the next question to Alan.
Hello, I'm Dr. Arun Kapur from Nepal, currently practicing in ICU department of Cipla Provincial Hospital. My question is, as this pandemic we hope is coming to an end, what do you feel could be the biggest change happening in primary care practice in asthma?
Well, as I said, there's silver lining in everything. Some of the good changes are that people are masking, and we've had much less viral infection triggers, and overall less asthma exacerbations, which was surprising from what we expected at the beginning of this. Now that's going to change as masking mandates and so on lift and social distancing mandates lift. So we'll probably get back to where we were. Our influenza has been pretty well non-existent in Canada in terms of a viral issue. So that's been a good thing. The bad thing is, and I suppose another good thing would be the fact that with virtual visits, you actually are able to check inhaler technique. You can't do that on phone. So again, if you do have the ability to Zoom versus phone, you can do that. The downsides are probably things like, again, as we talked about, adherence, a little harder to get an idea, like unless you actually can hold their inhaler in their hand and see how many doses are left, you may not know things like that. So there's some things that may be missing based on that. And I think some of the comorbidities may also be a little more difficult to recognize with the absence of an in-person visit.
Sure. Nick, another question that's come, and I think that's specifically to Louis-Philippe, and that's about exercise-induced asthma. Louis-Philippe, that's been your area of significant interest and research.
I'm Dr. Sajid Kumar, working as internist in Bedal Sohar. So I have a question for you. In post-COVID asthmatic patients who have exercise-induced asthma, how can they restart the exercise after COVID? Do they have to take any precautions in restarting the exercise?
Well, there are no specific rules about that. I think if the patient can tolerate to do some exercise, even if it's not as good or as severe or an exercise as he was doing before, if it's milder, I think they should not stop exercising. If they are unable to do just a minimal exercise, at least they should do this. So it depends on the symptoms. It depends on the tolerance of the patient. Of course, as I said, if it's asthma, well, usually we should get control as soon as possible. And as soon as asthma is at a minimal control, then they can start again to train with moderation initially, but progressively. If it's a long COVID, really, we're sure it's a long COVID associated. We have to decide what kind of problem they have. Is it a problem of some fibrosis? Is it some inflammatory process that is still keep bothering them? We have to be cautious. But once again, I think the basic stuff is tolerance of the patient in regard to symptoms, and I would suggest monitoring oximetry, at least do some exercise tests initially with oximetry to see if they don't desaturate too much.
Good. Fantastic. From an exercise specialist, that's great information. Thank you, Louis. Alan, question to you, and this is the last question to you. As a GP, you have been having challenges, I'm sure, vaccinating your allergic patients with asthma. Has it thrown up a challenge for you, or has it been smooth sailing of late?
Well, the risk really is people getting anaphylaxis from the messenger RNA vaccines, as you well know.
Right.
So that has been a concern for people who've had anaphylaxis in the past.
Right.
Asthmatics themselves are actually not a higher risk of getting anaphylaxis. They're quite unrelated issues.
Sure.
So there's been two issues with this. Number one is people who truly do have anaphylaxis and having to make sure that they see an allergist and decide about their next vaccine.
Right.
The other issue, of course, has been a lot of people who've been vaccine hesitant. And because of that concern about anaphylaxis, they've wanted exemptions and so on. And our government's been very clear about actually listening to us as clinicians to say, hey, that's not an exemption reason, and that's not good enough. So we've had that as a bit of an issue as well. But for the most part, no, it hasn't been a problem. Although I would just like to mention that don't forget we have other vaccines to give of tetanus and pertussis. We still have pneumonia vaccines, which should be given to our asthmatics as well, and even things like shingles vaccine to our older patients. So remember, those other vaccines have to, and influenza, of course, they have to be given as well.
Yeah, I think the hesitancy for all these vaccines has come down actually after COVID. So that's been a good thing. So thank you, Alan and Louis-Philippe. It's been a wonderful interaction, 2 outstanding cases and 2 short presentations that really deliver messages strongly to primary care physicians across the world. Thank you very much for your time. I would again like to thank our collaborators, which are the Sri Lanka College of Pulmonology, Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPATH from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. To inform you all, the episodes of Healthcare Superstars are now archived. To watch them, please register on the app that you can see on your screen now and deep dive into the world of Healthcare Superstars. Thanks to all the participants for your active participation. We have received an overwhelming number of questions, and for the answers to the same, please stay tuned for the FAQ section in the archive section for episode 10. We also look forward to your valuable feedback before you log out from the session. And I look forward to meeting you again in Season 2, Episode 11, very soon. Thank you.